Hi, it's Patrick Hutzel from IntensiveCareHotline.com, where we instantly improve the lives for families of critically ill patients in intensive care so that you can make informed decisions, have peace of mind, real power, real control, and so that you can influence decision making fast, even if you're not a doctor or a nurse in intensive care. This is another episode of Your Questions Answered, and in last week's episode I answered another question from one of our readers, and the question last week was, my mum is admitted to ICU with an infection. Why do the ICU doctors keep on convincing me to put my mum into a DNR status? Help. You can check out last week's question by clicking on the link below this video. In this week's episode of Your Questions Answered, I want to answer questions that we get quite frequently as part of my one-on-one consulting and advocacy service, and it's simply a question that also people write in about all the time. So today's question is, after coming off the ventilator, is there a chance to go again ventilated? So let's look at this closer. Taking patients off a ventilator in ICU is usually a gradual process, often referred to as weaning. There are numerous articles that describe this process in detail, and clear protocols have been developed. Assessment of a patient's readiness for removal of the breathing tube or endotracheal tube in ICU is based on ability to maintain patent upper airway, ability to cough and clear secretions, ability to follow 4 simple tasks, i.e. open eyes, track with eyes, grasp or squeeze with hands, and stick out tongue. Next, adequate ABG, also known as arterial blood gas, and obviously sitting up in bed. So reintubation is common following extubation. Intubation is the reinsertion of the breathing tube, and extubation is the removal of the breathing tube. And so reintubation is common following extubation and discontinuation of mechanical ventilation. Extubation failure rate considered acceptable has empirically been set at 10 to 15%, but avoiding reintubation remains an important clinical goal. Extubation failure and need for reintubation within 72 hours of extubation is common in intensive care units or ICUs. It can cause increased morbidity, higher costs, higher ICU and hospital length of stay, and also higher mortality. Due to the high economic and personal costs of prolonged weaning and extubation failure, it is imperative that the critical care nurse monitor factors such as patient discomfort, fatigue, sweating, work of breathing, mental status, and vital signs during weaning. In addition, measures such as these can be taken prior to the start of a spontaneous breathing trial to encourage successful spontaneous breathing. Also important is optimizing muscle strength by providing adequate nutrition, avoiding neuromuscular blockers that paralyze the muscles that are necessary for breathing, like cisatracurium or rocuronium, decreasing steroid use and normalizing electrolytes. Decreasing respiratory work by placing the patient in an upright position, decreasing respiratory demand and resistance, and increasing respiratory compliance. Optimizing ventilator drive by reducing or stopping sedative medications. Increasing oxygen carrying capacity by avoiding factors that cause atelectasis or collapse of the lungs, correcting anemia and blood gases imbalances. Addressing cardiac dysfunction and oxygen carrying capacity. Promoting sputum clearance and mobilization as appropriate. We also have another related article and video on our website that breaks this down in more detail, and we have linked on it towards this video in the written version of this article. And the article and video is how to wean a critically ill patient in intensive care off the ventilator and the breathing tube. Next, who is at risk for extubation failure? patients with advanced age, high severity of illness at ICU admission and extubation, pre-existing chronic respiratory and cardiovascular disorders, unresolved illness, development and progression of organ failure during the time from extubation to re-intubation, prolonged sedation and prolonged induced coma. Re-intubation itself have been proposed as reasons for increased mortality and morbidity. Next, parameters used to predict extubation failure can be categorized into assessing respiratory mechanics, assessing airway patency and protection, cardiovascular reserve. The intensivist needs to identify patients at high risk of extubation failure and be prepared to reinstitute ventilation early to prevent adverse outcomes. Also, necessary for successful extubation is adequate cough strength, minimal secretions, alertness, stable vital signs, acceptable blood gas results and chest X-ray. Another related article and video we have to this topic is how long does it take to come off ventilator or respirator in intensive care. Again, we put a link below this video in the written version of this blog. Let's now look at failed extubation consequences. To predict extubation failure is essential, as both delayed and failed extubation have detrimental consequences such as prolonged ventilation and ICU stay, also need for tracheostomy, increased cost of treatment and mortality. Let's look at causes of extubation failure. Poor nutrition, decreased level of consciousness due to persistent effects of sedative and analgesics, neurological impairment due to primary illness, respiratory failure which manifests with increased work of breathing, accessory muscle use, hypoxia. Failure to maintain airway patency due to upper airway edema seen in patients with prolonged translaryngeal intubation and evident stridor. Excessive secretions coupled with inadequate muscle strength and glottic incompetence, and prolonged sedation and induced coma. So next, what is an unplanned extubation? Endotracheal intubation is always being done in the hospital for patients who have and may have problems with their airway, and it's very important to monitor closely these patients to always secure the breathing tube in place to avoid unplanned extubation. An unplanned extubation occurs when a patient is on mechanical ventilation and their endotracheal tube is removed when it wasn't supposed to be. If the patient themselves intentionally removes their own tubes, this is known as self-extubation or deliberate unplanned extubation. Whereas if the tube is removed by health professionals or a patient removes it by accident, it is referred to as accidental extubation. Unplanned extubation can increase the amount of time a patient must remain on mechanical ventilation, the duration of the patient's hospital stay, and the patient's medical costs. It's also estimated that 60% of patients who experience an unplanned extubation require reintubation, which may increase the risk of ventilator-associated pneumonia. Next, management of failed extubation. A reasonable strategy to prevent failed extubation, if anticipated, can be continued ventilation, treatment of remediable causes of muscle weakness and excessive secretions, daily assessment for readiness to extubate. Specific therapies can be used only when the cause for failed extubation is known. If extubation failure is due to cardiac failure, adequate anti-failure with diuretics and vasodilators can be instituted and then extubation attempted. Performing tracheostomy is another option. However, the problem of removing artificial airway still remains and tracheostomy has its own complications. Only two options seem promising in failed extubation: non-invasive ventilation and prophylactic steroids. Intubation is one of the integral parts of the hospital procedures as it is considered as an emergent life support measure. Being able to successfully remove the breathing tube of your loved one or wean them from a ventilator requires prompt and proper implementation of the successful extubation recommendations to avoid getting your loved one again ventilated. Such circumstance needs that the critical care nurses and the team serve as leaders in the adoption of the above recommendations to ensure that patients receive the highest quality of care during mechanical ventilation, weaning, and successful extubation. We have also put some references for this article below this video on our website, so you can see where we've got some of the information from. So, how can you become the best advocate for your critically ill loved one? How can you make informed decisions, get peace of mind, control, power, and influence quickly whilst your loved one is critically ill in intensive care? You will get to that all-important feeling of making informed decisions, get peace of mind, control, power, and influence when you download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn quickly how to make informed decisions, get peace of mind, real power, and real control, and how you can influence decision-making fast whilst your loved one is critically ill in intensive care. Your free Instant Impact Report gives you in-depth insight that you must know whilst your loved one is critically ill or is even dying in intensive care. Sign up and download your free Instant Impact Report now by entering your email below. In your free Instant Impact Report, you will learn how to speak the secret intensive care language so that the doctors and the nurses know straight away that you are an insider and that you know and understand what's really happening in intensive care. In your free report, you will also discover how to ask the doctors and the nurses the right questions, discover the many competing interests in intensive care and how your critically ill loved one's treatment may depend on those competing interests, how to eliminate fear, frustration, stress, struggle, and vulnerability even if your loved one is dying. You will get 5 mind-blowing tips and strategies helping you to get on the right path to making informed decisions, get peace of mind, control, power, and influence in your situation. You will get real-world examples that you can easily adapt to your and your critically ill loved one's situation. How to stop being intimidated by the intensive care team and how you will be seen as equals. You will get crucial behind-the-scenes insight so that you know and understand what's really happening in intensive care and how you need to manage doctors and nurses in intensive care, and it's not what you think. Thank you for tuning into this week's Your Questions Answered episode, and I'll see you again next week in another update. Make sure you also have a look at our blog section for more tips and strategies, or send me an email to support@intensivecarehotline.com with your questions. Also, have a look at our membership site intensivecaresupport.org for families of critically ill patients in intensive care. You can also call me, find phone numbers on the top of the website at intensivecarehotline.com. Also, have a look at our ebook section, and you can get one-on-one consulting and advocacy with me over the phone, via Skype and via email by clicking on the relevant tabs on the top of the website, or again just by giving me a call on one of the numbers on the top of the website. This is Patrick Hutzel from intensivecarehotline.com, and I'll see you again next week in another update.